Well, let me start by thanking the organizers and in particular the foundation for inviting me to speak here. I've done this quite a bit. I always find it very exciting, a very fulfilling effort, and I've often said that I would, if I had to, fly through a hurricane to get here, and I think I did that last night actually. And then I also apologize for the fact that my slides are not in the book. I did bring 100 copies of them. I didn't realize we're going to have 200 to 300 people here. So if, in fact, you don't have it and you'd want one, if you email me, I'll email you the slide deck with no problem. The bill will be in the mail, but that's okay. All right, so the topic today is the future of ovarian cancer treatment, personalized medicine. And what I'd like to convey to you is what I think is quite an exciting revolution we're undergoing in terms of the treatment of ovarian cancer. And if you leave this auditorium simply with the idea being that ovarian cancer is actually a series of different diseases and should be treated differently, then I will have accomplished something. The clinical problem has already been discussed. I just list this here to point out that it's a big problem in women's health. It's a very responsive tumor to chemotherapy. I would say, in fact, it's probably the most chemo-responsive epithelial cancer, even higher than breast. Unfortunately, the tumor comes back, develops drug resistance, and because it presents at an advanced stage, it does have the highest case fatality rate for gynecologic cancers. Now, the interesting issue, as was summarized very well by Dr. Hoskins earlier in the day, is the fact that, frankly, we've evolved a paradigm here where all ovarian cancers essentially are treated with surgery and then platinum and Taxol, and that's the standard of care, and it's really not changed much since the 1990s, although I think in the information I'm going to show you in a few minutes, it's going to rapidly evolve in the next couple of years. So it really asks the question, are all ovarian cancers the same? I'm going to go through just some summary of some data to argue the case that, in fact, they're not. So here's a slide that summarizes the way in which different ovarian cancers, based on histology, meaning how they look under the microscope, present. And we know that, in fact, serous tumors, which is serous tumors, which are the most common, present at advanced stage. If you look at mucinous tumors and clear cells, this should be mucinous here, in fact, they present in local stage. So there's a difference right there in terms of biology. We also know that clear cell cancers are actually more resistant to chemotherapy. Mucinous tumors, although have an overall better survival because they can be cut out and removed, when they become advanced stage, are also less responsive to chemotherapy. But again, remember, all patients get treated the same way. So what's also changed? Well, we've got a lot of new molecular technologies, a lot of interesting things coming out of the lab, which I think have really set the table to reinforce that these are different tumors. What you're staring at here is a microarray. This is actually the size of the end of your pinky. And all of these crazy dots here are genes. We can measure 35,000 genes simultaneously. And it's this kind of technology that's just given us an ability to look at these tumors in a whole different way and ask, are they different? Are they the same? Should they be treated with the same drugs? And I'll show you an example in clear cell of work that we did, but several other labs have contributed to this. And you see something like this. Now, what is this? There's a lot of arrows and dots. Well, what you're actually seeing here is each one of these blobs is a gene. And it's color-coded because it's telling you that this gene is abnormally expressed in clear cell cancers as opposed to serous cancers. And they are all connected in a pathway that works through this gene. It's a master gene that controls both metabolism and the ability for the cell to grow under anoxic conditions, meaning no oxygen. And so this kind of work demonstrated that clear cell cancers of the ovary are very different than serous cancers. And that, in fact, if you really want to treat clear cell cancers, maybe we should start getting away from carboplatin and Taxol and start treating these pathways. This kind of data got into the gynecologic oncology group. It got into the field. And we, in fact, have now started to conduct clear cell specific trials. So this is really a paradigm shifting break, and I think you're going to see a lot more of this. GOG 268 is an upfront trial that is using carboplatin and Taxol because we still think they are somewhat active, but it's combining it with what's called an mTOR inhibitor. mTOR affects the metabolism of the cell, and as I said before, we have good data that suggests clear cells are really dependent upon metabolism. This is another trial that I believe is just closed, which is for recurrent clear cell cancers, which is using a drug called sunitinib, which is a TKI inhibitor, tyrosine kinase inhibitor, that targets the VEGF receptors. Those are receptors that are involved in blood supply. And remember, I mentioned to you that the pathways in clear cells are important in anoxic conditions, so they're very dependent upon blood flow. So you're now getting specific trials, and my prediction is in another 3 or 4 years, these regimens will not look very similar to what you're seeing in serous cancers. Here's another example. I won't show you the molecular biology, but mucinous tumors have always been known to be very odd. They're very different than the other ovarian cancers. In fact, they seem to look like and behave like GI tumors. And so the present GOG trial is listed here. It's a phase 3 trial. It's a randomization. It's comparing sort of standard therapy to oxaliplatin and capecitabine, and it adds bevacizumab. This is a very much GI type regimen, and I think that makes sense. This trial is accruing, although it's accruing slowly because these tumors are fairly rare. Now that's histology. What about grade? I don't know how much you know about grade, but again, when the pathologist looks under the microscope, they tell us what it looks like, and they also tell us how ugly the cells are. That's grade. If it's really ugly, it's high grade. If it's well behaved, it's low grade. Again, the pathologist has been telling us for years these things look different, but we've kind of ignored it. And so we treat low grade and high grade the same. And this data showing here tells us that's probably not smart. So this is the percent of tumors presenting with advanced stage. These are low grades. 20 to 30% present with advanced stage. High grade, very common. So right there we know the biology is very different. And then there's other data about long-term survival, the growth rate, low grades, low malignant potential tumors would appear to be very different. Well, without going into too much of the molecular biology, I can show you they look different right here. This is low grades. This is high grades right here. The molecular biology tells us that, in fact, not only are they very different, they may even be completely different diseases. And the present theory is that the surface epithelium, whether it be of the ovary or the fallopian tube, has two choices when it becomes malignant. It can go to LMP in low grade, or it can go to high grade. This is probably determined by what happens to a gene called P53. And then to become fully low grade, these genes are mutated. That's important because we've now built on that a very specific trial for low grades using the AstraZeneca drug 6244, which inhibits a gene called MEK. MEK is downstream from RAS and RAF. It's very specific for those genes that are mutated in low grades. This trial is finished. It's been published. It's a simple pill, extremely well tolerated. The clinical benefit rate was 80%. Now, I remind you, historically, we've treated low grades just like high grades. Ladies get Doxil, they get carboplatin, Taxol, weekly Taxol. They get a lot of drugs, which are relatively toxic. We're now entering the world of small molecule inhibitors, well tolerated, clinical benefit rate 80%. This is another way of looking at it. This is comparing the trial to the MD Anderson experience. And again, I simply point out that the progression-free survival is substantially different, strongly arguing that this pathway is important for this particular tumor, and this pathway isn't present or active in high-grade tumors. Keep your eyes open because this is one future trial which is going to open soon. It's combining a different MEK inhibitor right here, and it's combining it with the PI3 kinase inhibitor. I'm particularly biased on this because I'm the PI on this, but there's at least 2 other trials that are going to open that have drugs specific for low-grade serous cancer of the ovary. Okay, so here's a summary slide. We now know that ovarian cancer is different. It looks different. It even looks different grossly. And these different types of tumors have different origins, different pathways, and are almost assuredly going to be treated with very specific regimens. Now, probably what everybody's sitting here asking is, okay, can we get beyond the rare tumors and start talking about the one that really counts, which is high-grade ovarian cancer? And certainly that's where the bulk of the work is ongoing, and I think a little bit more challenging. So again, what's changed about this is that we were able to clone the human genome back in 2001. We now have all these technologies, as I pointed out before, where we can measure 35,000 genes simultaneously. We can measure the amount of gene copy numbers in a tumor. We can measure the degree of methylation. It just goes on and on and on. I can write the grants, I get a little money, I have a lot of fun, but the truth of the matter is, what counts is, can we get information that allow us to personalize our therapies for patients? So the NCI undertook something called the Cancer Genome Atlas. It was alluded to before. I'm not going to go into details, but essentially what they did is they took that human genome cloning technology and they applied it to about 500 ovarian cancers. And they analyzed them seven ways to Sunday. And this is sort of a summary, and the details here aren't all important, but the take-home message is, as opposed to lung cancer, brain cancer, GI cancer, where you find specific genes with high levels of mutation, right? Lung cancer, EGFR mutations, 10-15%. Glioblastoma, you can find genes mutated at a rate of maybe 15 to 20%. Colon cancer, KRAS, common mutations. And these are sometimes targetable. In ovary, you do not find that. The only genes mutated frequently are BRCA1 and 2 and P53. What you do see, though, is this. It's a little complicated, but let me just point you to this side, not this side. This side is actually all the chromosomes. These are chromosomes, 8, 9, 10. And what you're seeing here, these lines, reflect areas of the chromosome where there's extra DNA. It's not supposed to be there. These genes have been amplified. They've been increased. And you can see this pattern is pretty robust. I mean, these are huge areas of the chromosomes that have been duplicated. In addition, you see this. This is the same chromosomes, and what you're looking at here are areas in which DNA has been deleted. It's missing. It's gone. This, again, is very robust. Look at these areas. These are very large areas where DNA is missing. And that gives you the following picture. This is what's called spectral karyotyping. What you actually do is you paint the chromosomes with a floor that has a color on it. Each chromosome gets a different color. What you should see are 2 chromosomes, right? For each chromosome should have 2 pairs, 1 pair, 2. And it should be a solid color. So take a look at this. This is an ovarian cancer. First of all, you got 3 up here. Here you got 4. Here you've got what looks like some sort of, modern art where you've got colors of all over this chromosome. This means the DNA has come from another chromosome and been inserted there. Look at this. You got 5 here, all modeled with different colors. What this reflects is that ovarian cancer is somewhat special, not super high mutation rates as we see in other tumors, but in fact we have chromosomes that can't get their act together, and DNA moves around and gets deleted and gets amplified. Now there are consequences of this, and it has been said at major public meetings, not by me, but by others that say, okay, there are consequences of this, and here are the consequences. Subsets of high-grade serous ovarian cancer do not exist. You cannot tell one tumor from the other. Tumors are so genomically abnormal, they're adapting and they're moving. Therefore, they may not be able to be treated by targetable agents, no mutations to target, and they may not be predictable. We may not be able to tell what this lady will do versus this lady. Well, that's a little upsetting. I don't happen to share that, and I'll tell you why. Because you just think of new ideas to kind of approach this. The point is that it is a unique tumor, and there's a certain amount of genomic instability. But I think with some clever thinking and more research, we will be able to target this. So first of all, if this tumor has such genomic instability, is that because it has a DNA repair abnormality? And can we actually exploit that? And the answer, I think, is yes. It has a DNA repair abnormality because BRCA1 and 2, these are repair enzymes, are mutated. And P53 is frequently mutated, and that's also a big DNA repair gene. So you probably have all heard of PARP. It was covered before. PARPs are interesting new drugs, which in fact may be able to exploit this component of ovarian cancer. So this is a simple diagram of how PARP inhibitors work. It was covered before, but I'll just point out two things. First of all, your DNA, my DNA, everybody's DNA is undergoing abnormalities every day, including breaks. DNA has two strands. When you break a strand, it has to be repaired. The repair enzyme is PARP. If you inhibit PARP, you don't repair the single-stranded break, but you got two strands. The DNA is still intact. But what happens when you don't repair single-stranded breaks is they become double. The whole piece of DNA breaks. But the cell is smart, and the cell can repair double-stranded breaks also down here. But in order to do that, it needs a repair complex that contains BRCA1 and BRCA2. So now you see the picture, and this was wonderful work done in a number of labs, particularly Alan Ashworth's over in the UK. He said patients who have tumors that do not have functional BRCA1 and 2, those tumors should be exquisitely sensitive to PARP inhibitors. And they proved it in the lab. It was beautiful. And then we went into clinical trial, and you can see here, this is one of the early ones. These are germline BRCA1 ovarian patients. Here's the dose of the drug. Look at the response rates. These are patients with fairly aggressive resistant tumors, 33% response rate. Median PFS, the difference here is quite spectacular. Perhaps it looks better on the waterfall plot. Remember on these plots, this is tumor shrinkage, this is tumor growth, and you can see the vast majority of tumors here, single agent, 400 milligrams, are seeing most of what we think is really spectacular response. This is a pill, you take it, fairly minimal side effects, maybe a little mental confusion, although frankly I've never seen it, except in myself. Some nausea, low-grade nausea, fatigue. There's been a number of PARP trials. I'm not going to go through them all. I just wanted to emphasize this one because it was recently represented at ASCO. This was the AstraZeneca consolidation trial, and this is slightly different than what I showed you before, which was recurrent tumor. This is now recurrent tumor that has been treated with standard chemotherapy, and the tumor is gone. So their patients are in remission. They get randomized to the PARP inhibitor plus a placebo. So this is what's called a maintenance trial. And this was presented a year ago. If you get the PARP, you're out here. If you don't get the PARP, you're in here. Hazard ratios, which probably don't mean much to you, but that kind of summarizes the whole difference rather than just taking a single point. 0.35, pretty impressive. Look at this p-value. There's tons and tons of zeros here. That's very good. This was represented at ASCO literally a week ago, looking only at the BRCA1 and 2 patients, because this was a heterogeneous group. This hazard ratio goes down to 0.1. I've never actually seen a hazard ratio that low. So I think most of us feel that, in fact, in certain populations, this is an active drug, and those populations probably are patients with tumors that have a homologous recombination deficiency, meaning the tumor cannot repair its DNA. Now, the real question is that only patients with germline mutation in BRCA1 and BRCA2? And the answer, I think, pretty strongly is no. Okay, it can include BRCA1, BRCA2 germline, but it may also include patients who have normal germline situation, but the tumor itself has lost BRCA1 and 2, either by that DNA is missing, or maybe it gets methylated and shut down. This is still an area of active research, but if you add up all of this, it may be up to 50% of ovarian cancers have this defect, and therefore patients can benefit from PARP inhibitors. So that certainly is clear stratification and personalization for approach in these serous tumors. I'll bring this to your attention because I'm sure this is relevant. In the next 6 to 12 months, there will be 2 AstraZeneca phase 3 trials opening with PARP inhibitors. These are, at least one of them, I think maybe both of them are registration trials. Tesaro, which is a company that's licensed the old Merck PARP inhibitor, which had been abandoned, is opening a randomized phase 3 in the next couple of months. That is also a reasonably good PARP inhibitor. And then there are 2 Clovis trials. Clovis licensed the Pfizer drug, and they're going to be opening in the next 6 to 12 months. So here a PARP, there a PARP, everywhere a PARP. These are finally going to become available, and I would predict that there'll be at least one, maybe 2, that will reach some sort of license and approval by the FDA in another 2 to 3 years. Okay, so that's homologous recombination deficiency and genomic instability. But can we stratify other patients? In what way can we do this? Well, it was mentioned before, debulking is very important. Patients who can be completely debulked do better than patients who can't be debulked. And perhaps if we knew that ahead of time, we could stratify patients to perhaps not get debulked and get chemo up front, or maybe they could even go on an experimental medicine if we knew that the surgery was not going to get that patient to where they need it to be. So this is data that's not published, actually, although somebody's probably ripping it to shreds right now because it came from my lab. But we looked at about 1,800 of those microarrays that are out in the public domain. So you're looking at 1,800 tumors, and you're looking at 35,000 genes on them. And we create this huge database, and we asked the question, could we find a gene signature, a gene expression signature that would tell us which patients can be debulked and which can't? And the answer was sort of surprising to me because the answer was, we think we can. This is the pathway. Now, this looks a little ugly, but it's really not that ugly in the sense that these are all the genes, all the red genes are in the signature, and they're all centered around a couple things. Tumor invasion from TGF-beta signaling, which probably doesn't mean much to you, but TGF-beta is a very potent ligand. It's been around for a number of years. And then there's this what's called EMT transformation. These are biologic processes that cause tumors to sort of spread out and invade on surfaces, which if you think about it may very well be what makes a patient's tumor not debulkable, because it's spread out in all sorts of locations as opposed to being single tumors where the surgeon can take it out. We've actually gone on to validate this, not by gene expression, but by staining the tumor for the proteins. So this dark stuff is the actual protein. And the only thing you need to look at is this box right down here. This summarizes all of the staining. It adds it all together, and it creates this curve here. And the area under the curve tells you how potent is this as a predictor. The area under the curve here is at 0.89. That translates into a 94% accuracy to predict for the surgeon, for the patient, whether a patient will actually benefit from that surgery. So we think that maybe we're getting onto something here where we may also have a test up front when the patients present to say, look, you're going to benefit from surgery, you go, or you're not, you need chemo first, then interval debulking. Or potentially, we think you need an experimental therapy. So again, we're stratifying patients. Okay, almost finished. Can we identify other patient subsets? Because remember, I said PARP sensitivity is maybe 50%. We got a lot of genomic instability. Are there other things we can do? There are naysayers to say this is too genomically plastic. I personally think that that's not true. And even in those patients who don't have homologous recombination deficiency, we'll be able to identify actionable targets. And here's an example of one. So I want to go back to the amplification image. Remember, these chromosomes have these big areas where you have extra DNA and extra genes. Not mutation, but extra genes. And we think, and a lot of others think, that these are the so-called drivers of the tumor, meaning extra copies gives rise to extra expression, and those bad genes drive the tumor to grow. Here's an example. There's a chromosome 5q, it's just a name, but there's an area there that, in fact, you've got extra copies of genes. And if you look at patients who don't have that and compare it to patients who do, there's a huge difference in how well the patients do. If you look carefully at that area, there are a fair amount of genes. So this is the challenge in ovarian cancer. Which is the important gene? Well, it turns out, way out here, there's something called FGF18. This is a little protein that floats around, and it binds to FGF4. They're right next to each other, and they're both amplified, okay, in about 25% of patients. If you take that and go into the lab, and this is probably boring stuff for you, but I make my living doing this, and if you actually put it into animals, if there's no expression, you get a little tiny tumor here. This is what happens when you express FGF18 in the cell line and you put it into an animal. This tumor is massive. And in fact, if you look really closely, I don't have the pictures, it's all red. These tumors have massive amounts of blood vessels, because that's what FGF does. And it's very similar to the human tumors that have this amplicon. Okay? And there's another slight twist to this, which we found quite interesting. It turns out if you look carefully at these tumors, these are the tumors here, they're dividing very quickly. They have a lot of blood vessels, see them down here. But if you look really closely, you see this. This is a massive infiltration of the tumor by macrophages. Macrophages are our friends. Macrophages help us live, but sometimes they do bad things. And in this case, they're being recruited into the tumor, and the macrophages are helping the tumor to grow faster. So this is the kind of work that's going to happen in the next couple years, where we map out all these amplicons. But if we can't act on it, then it doesn't help us. Well, in fact, as a pathway, I think we can act on it. So for in this particular case, a company who will go unmentioned has produced something called FGF trap. And FGF trap is actually the FGF receptor glued together. They make a molecule out of it. They've gone through preclinical testing. They're already into humans. When you inject it, it soaks up all of the FGF. And in fact, they have an FGF trap molecule that is specific for FGF18. So I would propose, here's a perfect example. Map out a tumor, patient has an amplicon, FGF18, they go into the queue to receive FGF trap. Now, let's say the response is great, but the tumor comes back again. We look at the tumor again, and maybe we'll find an amplicon somewhere else with a different gene, and that'll tell us then to use a different molecule. And I think this is the future of the treatment for ovarian cancer. So in conclusion, I would say, take home the messages. Ovarian cancer is a heterogeneous disease. It's not a single disease. Histologic and grade differences, those patients have to be treated differently, and they already are. Serous cancer is the big challenge. Lots of genomic instability. We can actually exploit that. But I think we're going to get into a situation where, at a minimum, we will change ovarian cancer into a chronic disease. I tell my patients all the time, if I get to the point where I can keep typing your tumor and you keep coming back and I keep treating you in a different molecule and it's not that toxic and you're living your life, what do you think? They say, that sounds terrific. And I say, and you get to see me every month. What could be wrong? Okay? So personalized medicine is coming. I put this little picture here. I ripped this off from Alicia Sequest, who's one of our docs in lung cancer. But this is sort of the model. This was what Bill Hoskins summarized. We have a patient group, ovarian cancer, and they all get carboplatin and Taxol, and it's worked well, but we know we want to do better. And so now we're beginning to split out patients based on low grades, clear cells, BRCA-like. Maybe we could find the patients who can't be debulked right and stratify them into a different treatment paradigm. And with that, I will end, and thank you very much for your attention.